Perfect.
Yeah.
Perfect. Thank you very much for the invitation. It's lovely to be here. And whilst I'm definitely a Francophile, I think it's fair to say I'm definitely not a Francophone, and I'm very sorry that I will be presenting in English. Benjamin has told me that the rest of the meeting will be conducted in French. I don't think it would be in anyone's interest if I tried to speak this presentation in French. So I'm going to talk about anti-glomerular basement membrane disease today, and it's going to be a case-based presentation. And time permitting, I'm going to present hopefully 5 cases that really illustrate the spectrum of anti-GBM disease and current approaches to treatment. So the first case is a case of a 29-year-old female waitress who, as it happens, was from France, who presented to us in 2019 without any past medical history. She was a non-smoker, and her presenting symptoms were with 1 week of fever, loin pain, and visible hematuria. She had not inappropriately been treated by her general practitioner for a urinary tract infection, but she continued to have symptoms of low-grade fever, and when she presented to hospital, her systems examination was unremarkable, though she did have evidence of some blood and leukocyturia in her urine dip, but no proteinuria and nitrites were negative. Her initial blood test showed a creatinine of 290 and a CRP of 152. She had normal chest imaging. Given the acute kidney injury, she had some kidney imaging which showed unobstructed kidneys, but they were reported as large relative to body size, and she was treated initially for a bilateral pyelonephritis. But over the course of a 5-day admission to hospital, her kidney function did not get any better. Indeed, her creatinine rose to 454. And on day 5 of her admission, the general medical team thought there's something not quite right and referred her to the nephrologists. So she was transferred for an urgent kidney biopsy, and this showed a diffuse necrotizing and crescentic glomerulonephritis. There wasn't much in the way of background glomerular or interstitial scarring, but immunofluorescence did identify strong linear IgG. And on the same day as the biopsy was reported, we got the results of her serology from the immunology lab, and she had a high titer anti-GBM antibody at 220 units, was ANCA negative, and at this point her creatinine had risen to 512. So clearly a presentation really with rapidly progressive glomerulonephritis, secondary to anti-GBM disease. And so we initiated conventional treatment with plasma exchange, high-dose oral steroids, oral cyclophosphamide, along with adjunctive prophylaxis. And with that treatment, you can see there was a very pleasing improvement in her serum creatinine over the following few weeks. And indeed, during long-term follow-up, she had recovery to a completely normal GFR, was able to have a successful pregnancy 18 months after her diagnosis, despite having received oral cyclophosphamide treatment. And during long-term follow-up, she's had no relapses. So this is a very textbook case of anti-GBM disease. This is exactly how it presents. And despite a little bit of diagnostic delay with instituting aggressive treatment, this lady did very well. The second case is slightly less straightforward and illustrates some of the challenges. So this was a 51-year-old smoker who presented to us in October 2022 with a non-specific prodrome for about 4 weeks. And at presentation to hospital, he had a creatinine of 812. He was dialysis dependent, but was maintaining a urine output of about 0.8 litres per day. He had a high titer anti-GBM. It was off the top of the scale at greater than 650, and he was ANCA negative. Again, there was no evidence of lung hemorrhage on his chest imaging. And of course, he presented to us on a Friday afternoon, and we didn't have the possibility of performing a kidney biopsy until Monday. And so we just got on with empirical treatment with plasma exchange, oral cyclophosphamide. He received some rituximab and high-dose oral prednisolone. And despite that very aggressive treatment regimen, he had non-recovery of his kidney function over the following 2 weeks in hospital with progressive oligonuria. And after 14 plasma exchanges 2 weeks into his admission, we performed a kidney biopsy to really determine the futility of ongoing treatment. And this biopsy showed 11 of 15 glomes were obsolete, and the remainder had cellular or fibrocellular presence. At this point, his anti-GBM had fallen to 48. And so, rightly or wrongly, we made the decision to stop further treatment with plasma exchange because this really seemed like a futile situation. Despite 2 weeks of treatment, he had no normal glomeruli on his kidney biopsy, and he was discharged to continue on maintenance hemodialysis as an outpatient. Then, after 10 days on the dialysis unit, he re-presented with dyspnea and blood-stained sputum, a 2-gram drop in his hemoglobin, and his anti-GBM had rebounded to 280. And so I think this reflects an early pulmonary relapse or recrudescence of the disease, probably in the context of a pulmonary infection or some fluid overload on the dialysis unit after his discharge. So we reintroduced plasma exchange. In total, he had more than 20 plasma exchanges. And with that treatment, he had resolution of his lung hemorrhage with non-recovery of kidney function. He has since been transplanted. But during his treatment course, he had a number of complications, including CMV viremia, pneumonia, and new onset diabetes. So really highlighting some of the more challenging aspects of anti-GBM disease, including the effects of delayed diagnosis before starting treatment, how to manage ongoing antibody positivity in the face of patients who aren't going to recover kidney function, and of course, some of the complications of treatment, including infection. So these were two typical cases of anti-GBM disease, which, as you all know, is a vasculitis that affects the glomerular capillaries, pulmonary capillaries, or both. It presents with rapidly progressive glomerulonephritis and/or diffuse alveolar hemorrhage, and it is characterized by autoreactivity to the glomerular and the alveolar basement membrane. We now recognize it as an immune complex small vessel vasculitis within the Chapel Hill consensus nomenclature, and it sits here really as a glomerular and alveolar capillaritis. So historically, we recognize this disease as Goodpasture's syndrome or Goodpasture's disease. Ernest Goodpasture was an American pathologist from Tennessee who, during his training, I think, in Harvard during the flu pandemic in 1919, described a case of a young man who had fatal outcome following a influenza infection. And he attributed this presentation with rapidly progressive glomerulonephritis and a pneumonitis to a complication of influenza infection at the time. It wasn't then until the 1950s when some Australian pathologists, Stanton and Tyng, described a further 9 cases of young men presenting with this pulmonary renal syndrome. And it was actually these pathologists who attributed Ernest Goodpasture with the first description of this disease, and they coined the term Goodpasture disease or Goodpasture syndrome in reference to the first case from 1919. But of course, we don't know if any of these patients had either anti-GBM disease or ANCA vasculitis that we would recognize it today, because it wasn't until the 1960s and the 1970s and the explosion in laboratory immunological methods that we could begin to detect both circulating antibodies in the blood of patients with this syndrome and then bound in tissue. And it was the very beautiful experiments of Lerner, Glassick, and Dixon in 1967, I think, that demonstrated the direct pathogenicity of anti-GBM antibodies. So in these experiments, they eluted the antibodies from patients who had died or had a nephrectomy following a diagnosis of anti-GBM disease, and passively transferred these antibodies to non-human primates, to macaque monkeys. And the monkeys developed a rapidly progressive glomerulonephritis that completely recapitulated the syndrome that was seen in humans. So the first demonstration, I think, ever of the direct pathogenicity of any autoantibody. The first comprehensive clinical description of what we now recognize as anti-GBM disease came from Curtis Wilson and Frank Dixon in 1973. And then the first description of using plasma exchange and immunosuppression for treating this syndrome came from what was then the Royal Postgraduate Medical School in London and now Hammersmith Hospital and Imperial College London, where I work. And this was the first description of using plasma exchange and immunosuppression to treat this syndrome back in the 1970s. And these early treatment papers from the 1970s tell us a lot about what we still know about this disease today. So patients who present with high titer anti-GBM antibodies do worse. The immunosuppression and plasma exchange can get rid of these antibodies. If you get rid of the antibodies, the patients tend to do slightly better. So we now recognize that anti-GBM disease is a rare condition. It has an estimated incidence of 1 to 2 per million of the population per year. It historically has had a clear bimodal age distribution with a peak incidence in the 3rd and the 7th decades, and there is a slight male preponderance, particularly in younger patients. We recognize it in Caucasian and Asian populations, though it's less well described in populations from the global south, probably reflecting lack of data rather than an absence of the disease occurring. Unlike most of the diseases that we as a vasculitis group look after, relapse is incredibly uncommon. It relapses in fewer than 3% of patients, and so it really is a one and done disease. We recognize that there's a strong HLA association, so the vast majority of patients carry HLA DLB1501 alleles, but there are clearly other factors that are responsible for inciting disease, and these include pulmonary irritants such as cigarette smoking and hydrocarbon exposure, some other renal diseases like ANCA-associated vasculitis, infections, and more recently we're recognizing that medications, particularly systemic anti-cancer therapy, may trigger this disease in some individuals. And again, the identification of spatial and temporal clustering of cases, particularly from a nice study from Mark Little in Ireland a few years ago, supports a role for environmental triggers in triggering this disease in susceptible individuals. So we know that typical anti-GBM disease is almost invariably associated with the detection of autoantibodies to the alpha-3 chain of type 4 collagen in the glomerular basement membrane. As I've shown you, the transfer experiments confirm the direct pathogenicity of these antibodies. The clinical equivalent of that is performing kidney transplantation in the face of circulating antibodies. And when we do that, the disease recurs in about 50% of transplant recipients. We know that titer broadly correlates with the severity at presentation, and that treatment with plasma exchange and immunosuppression is associated with a better outcome by removing these antibodies. And the antibodies are predominantly of the IgG1 and IgG subclass. That makes perfect sense. These are pro-inflammatory effector function antibodies. And so we know that this really is a archetypal autoantibody-mediated disease. And studies in experimental models suggest there may be a role for directly nephrogenic T cell responses in disease pathogenesis, but these T cells have not been demonstrated yet in humans. Now, in addition to developing autoantibodies to the GBM, we know that conformational transition of the GBM epitope or the GBM antigen is an important factor in disease onset as well. So in health, the disease-relevant epitopes on the alpha-3 chain of type 4 collagen are usually sequestered within this quaternary structure, if I can point. I'm not sure this is working. Sequestered within the quaternary structure of this Goodpasture's epitope in the basement membrane. And we think that it is important that this quaternary structure is disrupted so that the pathogenic autoantibodies can bind. And this may account for the association of anti-GBM disease with other diseases or exposures that can disrupt the quaternary structure of the GBM, including infections, chemical irritants like cigarette smoke or hydrocarbons, and other kidney diseases like ANCA-associated vasculitis or membranous nephropathy. In the past few years, an increasing number of other autoantibody targets have been identified in anti-GBM disease. So there are reports of antibodies to other alpha chains in type 4 collagen, to laminin 521, to perlecan, to entactin, and peroxidase. I think these are very interesting findings. We don't yet really understand the clinical significance of these antibodies, whether they really exist as an epiphenomenon or whether they really have a pathogenic role. I think the antibodies to laminin 521 are probably the most convincing as having a role in the onset of lung hemorrhage, and they've been demonstrated to be pathogenic in some animal models. So as I've shown you, the disease usually presents with rapidly progressive glomerulonephritis and alveolar hemorrhage in about 50% of patients. A small proportion of patients may present with more indolent renal disease or what's been described as atypical anti-GBM disease, and we'll come back to that at the end of the talk. The diagnosis of the disease rests on the demonstration of either circulating or tissue-bound deposited anti-GBM antibodies alongside a typical clinical presentation with renal or lung injury. So circulating anti-GBM antibodies are typically identified using commercially available ELISAs or bead-based assays that are optimized to detect immunoglobulin G class antibodies to the alpha-3 chain of type 4 collagen. And these commercial assays have greater than 95 sensitivity and specificity. We recognize that a small proportion of patients may be negative by the serological assays, and there are a number of reasons why that might be, including the concept of the immunological sink. So these are high affinity, high avidity antibodies that are all bound in kidney or lung tissue, so we can't actually detect them in circulation. There are rare isotype variants of anti-GBM disease, which I'll talk about, including IgA and IgG4 mediated disease. And as I've highlighted, there are some epitope variants which won't be detected by these commercial assays that are really optimized to detect antibodies to the alpha-3 chain of type 4 collagen. The development of post-transplant anti-GBM disease in patients with a primary diagnosis of all ports is recognized. And again, we usually can't detect circulating antibodies in this situation because these antibodies recognize a neoepitope on the alpha-4 and alpha-5 chains that isn't detected by the commercial assays. There are a number of reasons why you might see false positive anti-GBM antibodies, and this is common with all of the serological assays we use in the autoimmune space. So we've seen false positive results in patients with polyclonal hypergammaglobulinemia of any cause, with HIV. There are exceptionally rare case reports of dairy allergy causing false positive immunological assays for anti-GBM because anti-bovine antibodies interact with the blocking solution on the immunoassays. So it's a little bit esoteric, but it's sometimes something I ask about when I encounter a patient with an unexpected false positive anti-GBM result. The detection of tissue-bound antibodies is typically achieved with direct immunofluorescence on frozen kidney tissue, where you see polyclonal IgG with or without complement deposits in the typical linear fashion. Immunoperoxidase on paraffin is sometimes used, but I would say it is much less sensitive. We do recognize there are sometimes false positive causes of linear IgG staining or basement membrane enhancement on the kidney biopsy, and these include diabetes, some of the dysproteinemias, and fibrillary GN. And so electron microscopy of the kidney biopsy can sometimes be useful to exclude these other pathologies. Rarely you can see false negative staining, and this is really when you have such disrupted glomerular architecture from a very aggressive GN that the typical linear staining isn't seen because there's no remaining intact basement membrane to demonstrate that. I think it's important to highlight that kidney biopsy can have a useful role in identifying these antibodies bound in tissue, even in patients with relatively mild or without kidney disease. So we have had some patients present with isolated lung hemorrhage who have been seronegative, but when we've performed a kidney biopsy, even in the face of no urinary abnormalities, we can detect tissue-bound antibodies in the kidney. So even in the absence of clinically evident kidney disease, a kidney biopsy can sometimes be useful to secure the diagnosis. Then the demonstration of renal injuries, of course, with kidney biopsy. This really is the most crescentic of the crescentic glomerulonephritides. So more than 95% of patients will have presence in the kidney biopsy, and usually it is diffuse crescentic involvement with more than 50% of glomeruli affected. These are typically synchronous crescents, all of the same age. That's the kind of characteristic hallmark of anti-GBM. And where you see asynchronous crescents with a mixture of fibrocellular and cellular crescents, or an extraglomerular arteritis in the kidney biopsy, you really have to think about a concomitant ANCA-associated vasculitis. The diagnosis of lung hemorrhage can be more challenging because we typically don't perform lung biopsies and there are no clear diagnostic criteria for lung hemorrhage, and really differentiating lung hemorrhage from fluid overload or uremic hemoptysis can be a common clinical challenge. But the diagnosis is usually made on the combination of cross-sectional imaging with some example images shown here. Bronchoalveolar lavage, which typically shows increasing blood content on serial washes, and more than 20% hemosiderin-laden macrophages in that wash is usually indicative of lung hemorrhage that's been present for more than 48 hours. So how do we treat this disease? So this slide summarizes the KDIGO recommendations from 2021, and sadly, we are still just using the combination of plasma exchange, cyclophosphamide, and glucocorticoids. So it gets a little depressing talking about anti-GBM disease at some of the more recent kidney meetings where we have lots of exciting new therapies coming through, and we're still using really quite an old-fashioned regimen for the treatment of anti-GBM. So plasma exchange is typically daily at high volume and continued until anti-GBM antibodies are negative. We don't have randomized control data, certainly until recently, to support this approach, but lots of observational data that suggests patients who receive plasma exchange do better. This isn't Pexivast, this isn't ANCA-vasculitis. I don't think there's any debate about the role of plasma exchange in anti-GBM. KDIGO recommends treating patients with oral cyclophosphamide, really because most of the literature has been with oral cyclophosphamide. And because this isn't a relapsing disease, we worry less about the cumulative exposure to cyclophosphamide over a patient's lifetime because they're unlikely to require retreatment. And that's, until recently at least, certainly still been my preference to use oral cyclophosphamide. And then we have a conventional oral glucocorticoid taper in most patients. We try to avoid using pulsed intravenous methylprednisolone, but I'm not didactic about that, and clearly in patients who are critically unwell with lung hemorrhage, that is often used. I think an important thing that I always tell my fellows when we're looking after these patients, that as well as the immunosuppression, it's really important to avoid pulmonary irritants because these really are the major risk factor for ongoing or recurrent lung hemorrhage. So we have a very low threshold for treating infection. We try to avoid pulmonary edema. I like to keep patients on the drier side of euvolemia. And it's always quite depressing to see a patient leave the ward to have a cigarette in between plasma exchange sessions for anti-GBM disease. So we do try to discourage smoking and vaping, particularly when they're having active treatment. So yeah, just highlighting that this is the treatment regimen that we described in the 1970s, and we're still using it 50 years later. So we really could be doing better than anti-GBM disease. How do people do with this treatment regimen? So this slide summarizes some of the larger series that have been published over the last 20 years in anti-GBM disease. And you can see that patient survival does look like it's improving. So increasing from around 75% back in papers that were published in the early 2000s, up to 92% in the more recent literature. So patients are living longer. I think that probably reflects better general medical care and better survival on dialysis in general, rather than better treatment of anti-GBM disease. Because when we look at kidney survival in these studies, there's really been no signal of improvement over the past 20 years. The majority of patients do not recover and do not sustain independent kidney function at 1 year. And that's really driven by this really poor signal of recovery from dialysis-dependent kidney injury. So a consistent finding across all the historic literature is if that your diagnosis is delayed until the point that you need dialysis, your chances of recovering from dialysis are around 10%. And so this really poor kidney survival overall is really driven by the absence of recovery from dialysis-dependent kidney injury. And that is why the KDIGO guidelines suggest you might not want to offer aggressive treatment to patients who've got a poor prognosis and are unlikely to recover kidney function. And that really comes from this data that was published by my colleague, Professor Jeremy Levy, back in 2001, where he looked at the long-term outcome of over 70 patients with anti-GBM disease, stratified for their presenting kidney status. And you can see that if patients presented with a creatinine of less than 500, they did very well. Even if they had a creatinine greater than 500 but weren't requiring dialysis, they still did quite well with 80% kidney survival at 1 year. But if you presented on dialysis, your renal recovery chances were less than 10%. And the figure on the right shows the relationship between your presenting dialysis status and your long-term outcome, or your presenting kidney status and your long-term outcome. And you can see that if patients were on dialysis at presentation with a high proportion of presence on their kidney biopsy, these are all hollow circles on the top right. None of these patients recovered from dialysis if you had a high proportion of presence and were dialysis dependent at presentation. And so that's where the recommendation within KDIGO comes from, that you may not want to consider treatment in patients with adverse clinical and histopathological factors. We do have more recent data to guide the interpretation of kidney pathology and anti-GBM disease. So this is now the largest histopathology study in anti-GBM from Silke Bricks, into which we contributed cases. The purpose of the study was first to investigate the use of the ANCA renal risk score in people with anti-GBM disease. And Silke did find in over 170 patients that the renal risk score for ANCA could stratify outcome in anti-GBM disease. But then going back and addressing prediction without using the ANCA risk score, what Silke found is that actually the combination of your dialysis status at presentation and the proportion of normal glomeruli on your kidney biopsy remain the most discriminative factor for predicting your long-term kidney outcome. What I would highlight, that even in patients who are dialysis dependent with fewer than 10% normal normal glomeruli on their kidney biopsy, around 15% of patients did recover kidney function. So still quite a guarded prognosis, but not completely hopeless. And perhaps if I was a patient and you offered me a 10 to 15% chance of not being on dialysis with treatment, I would certainly think about taking that. So I tend to consider treatment in all patients, and perhaps start treatment in all patients, and then consider early withdrawal in patients who aren't responding, particularly if they have these adverse factors, such as more than 100% presence, more than 50% glomerulosclerosis, or fewer than 10% glomeruli on their kidney biopsy. Of course, this recommendation is made in the absence of lung hemorrhage. Regardless of your kidney status, you should receive treatment if you have lung hemorrhage. I would also highlight that some form of modified immunosuppression, even in patients who aren't going to recover kidney function, may have a role in preparing patients for kidney transplantation. These antibodies hang around for 2 or 3 years, sometimes without immunosuppression. And during that time, patients cannot be transplanted because of the risk of recurrence. So we've certainly used rituximab or MMF for a period to expedite antibody clearance in patients who are dialysis dependent or who aren't going to recover, just to get them ready to the kidney transplant. So I'll move on to the third case. So this was a 60-year-old female non-smoker who had been diagnosed with asthma 6 months ago and then presented to us with 3 months of arthralgia, dyspnea, wheeze, red eye, and rash. She had a significant systemic inflammatory response with peripheral blood eosinophilia, and she had what was presumed to be an acute kidney injury with a creatinine of 184 and urinary abnormalities. She had a biopsy of her skin rash that showed a neutrophilic dermatosis, a bit like a Sweet syndrome. Her chest imaging was normal. She had a kidney biopsy given the acute kidney injury, and this showed a necrotizing and crescentic glomerulonephritis with unexpectedly linear fluorescence along the GBM and dual positivity for PR3 and anti-GBM antibodies. She received treatment with plasma exchange, cyclophosphamide, rituximab, and steroids and azathioprine maintenance. didn't tolerate azathioprine, so then was switched to MMF, and during long-term follow-up had a very reassuring improvement in her kidney function and immunological parameters. Then 3 years after initial diagnosis, whilst on azathioprine maintenance, she did exactly the same thing, well, nearly the same thing again. She represented with arthralgia rash, deteriorating kidney function, and a recrudescence of her PR3 ANCA, but this time without anti-GBM antibodies. A repeat kidney biopsy again showed a necrotizing GN. On this occasion, the biopsy was poorly immune, and she was retreated with cyclovas, our combination rituximab and cyclophosphamide regimen, and with that, had a recovery in her kidney function. So this clearly a patient, and actually she presented now about kind of 10, 12 years ago, and she's actually had several relapses from her PR3 disease over the course of that follow-up, but it's never relapsed her anti-GBM disease. So we all recognize that dual positivity for ANCA and anti-GBM occurs at much higher frequency than you would expect, given the overall rarity of these two diseases. My colleague again, Jeremy Levy, did a nice study again several years ago that looked at several thousand requests for immunological assays to our lab and found that 5% of the ANCA positive samples were positive for anti-GBM disease, and about a third of samples that were positive for anti-GBM antibodies were also dual positive for ANCA. More recently, we looked at the long-term clinical outcomes of these patients in a multi-center European cohort that included 41 patients with a diagnosis of single positive anti-GBM disease, 37 patients with a double positive anti-GBM disease, and a large cohort of patients with single positive AAV. And what we found is that the double positive anti-GBM ANCA patients had the age restriction of patients with AAV, so tended to present in the older age group, and they had a much longer prodrome before the onset or before the diagnosis, suggesting that it was actually the diagnosis of AAV that came first, and that this may in some way have triggered then a superimposed anti-GBM. At presentation, they had exactly the same features of disease severity as the single positive anti-GBM patients, with high proportions requiring dialysis, high proportions with lung hemorrhage. The majority of patients were positive for MPO, so more than 70%. When we looked at the long-term outcomes of these patients, patient survival overall was comparable among the three groups. Renal survival, as you might expect, was best in the single positive ANCA patients, worst in the patients with anti-GBM disease, and the patients with dual positivity had an intermediate renal outcome, which may reflect actually differences in the mechanism of kidney injury in that group, because unfortunately we didn't have kidney biopsies in this study, so we don't know whether all patients in the dual positive group had tissue-bound anti-GBM antibodies or whether some may have had a quasi-immune GN that was actually more responsive to treatment, and that may have accounted for this intermediate kidney outcome. The important thing, and as I've shown you with the case, is that the dual positive patients relapsed at exactly the same rate as patients with ANCA-associated vasculitis. So as I've told you, none of the single positive GBM patients relapsed, but the dual positive patients relapsed at exactly the same rate as single positive AAV. And so in the setting of dual positivity for ANCA, patients do require longer term maintenance immunosuppression to prevent the ANCA component of the disease relapsing. Now, what about some newer treatments for anti-GBM disease? So we're using rituximab for every other glomerular indication. There are lots of case series and case reports of anti-GBM treatment with rituximab in the literature. This was a study we worked on that was led by Andreas Kronbichler from Innsbruck, where we collated the data of all the published case reports of rituximab use in anti-GBM disease and found 67. About half of the patients received rituximab as first-line therapy and about half as a second-line therapy. These patients tended to be young and included a significant pediatric cohort. Kidney disease was severe at presentation, so the median creatinine was 426, and about half of patients were dialysis dependent, and a third had lung hemorrhage. Patients received concomitant treatment with steroids, plasma exchange, and cyclophosphamide. And looking at these published series, the patient survival overall was greater than 90%, and renal survival perhaps better than we would have expected at 67%. The signals were better in the younger patients, particularly the children, and in the patients who were not dialysis dependent at presentation. And so I think this is interesting and suggests that rituximab may have a role in anti-GBM disease, though my main concern about these series is that they're susceptible to a lot of publication bias, because if you've had a good outcome with your rituximab treatment, you're likely to publish it, and if patients haven't done so well, I think that's less likely to make it into the literature. So what have we done at Imperial? Well, we introduced a standardized regimen for adding rituximab to cyclophosphamide for anti-GBM disease back in 2019, based on our experience with using the combination in AAV. And this is some data that's been put together by one of my fellows, Makantha and Srikantha Raja. But small numbers, but 45 patients in total, 30 who've been treated with rituximab and 15 without rituximab. The rituximab and non-rituximab group are very similar in terms of the disease characteristics at baseline. And what we found in terms of treatment is that we have been able to use lower doses of cyclophosphamide in the patients who were treated with rituximab, so about a 50% reduction in overall cyclophosphamide exposure. We've been able to use slightly less plasma exchange, and the time to antibody negativity is slightly less in patients who receive rituximab. So fitting with our kind of rationale as an AAV that we can use rituximab as a cyclophosphamide-sparing therapy. But sadly, when we looked at the long-term outcomes of these patients, there really was no difference after the addition of rituximab. So whether you looked at survival overall, end-stage kidney disease-free survival, or complications like infections, the outcomes were very similar. And actually, as you can see on these graphs, the major determinant of your dialysis status long-term and your risk of infection is your dialysis status at presentation, because we know that dialysis dependence is a risk factor as well for infection. So may spare cyclophosphamide, but didn't really enhance outcomes, the use of rituximab in our experience. Now, of course, many of you will be familiar with IDES or imlifidase, the immunoglobulin degrading enzyme of strep pyogenes that's being investigated in a number of autoimmune indications at the moment. This is a bacterial cysteine endopeptidase that cleaves human IgG at the hinge region and completely neutralizes the effector functions of IgG. And this clearly evolved in strep pyogenes as a mechanism to evade the host response to antibodies by cleaving antibodies, and has now been exploited, as I said, therapeutically. A few years ago, Martin Segelmark from Sweden described compassionate use of imlifidase in 3 patients with severe or refractory anti-GBM disease and poor prognosis, where this was added on to standard therapy. And you can see in these graphs that treatment with imlifidase in the blue arrow led to very rapid cleavage of circulating anti-GBM antibodies, really within minutes of the imlifidase infusion. And what was nice about this study is that they performed post-treatment kidney biopsies, and were able to demonstrate that after imlifidase treatment, the enzyme had actually been able to cleave membrane-bound IgG, so the Fab fragments could still be found on the glomerular basement membrane, but no FC fragment. So perhaps a more effective treatment than plasma exchange, because it not only removes the circulating anti-GBM, but reaches the antibodies that plasma exchange can't, and neutralizes the effector functions of GBM antibodies at the basement membrane. This led to the Good IDES 1 study, which was an open-label study of 15 patients with anti-GBM disease and poor prognosis who received imlifidase alongside standard treatment. And again, in this study, we saw very rapid cleavage of anti-GBM antibodies after an imlifidase infusion. And this was associated with better than anticipated outcomes in these 15 patients. So these were all patients who had poor prognosis and were unlikely to have kidney survival at 6 months. But with imlifidase treatment, compared to historical matched controls based on clinical and histopathological matching, we had the finding that the outcomes of 67% kidney recovery were much better than we would have predicted based on historical matched controls. So this led to the Good IDES 2 study, which recently completed recruitment, and from which we had some headline data at the Anchor Workshop in Melbourne 2 months ago. So this was an open label phase 3 that recruited from around the world, European and USA sites. It recruited 50 patients, again with poor kidney prognosis, who received an imlifidase infusion alongside standard of care, with a primary endpoint of GFR at 6 months. And as you may know, we actually had a negative trial outcome from this study at the Melbourne meeting a few months ago, which was somewhat disappointing for those of us who had been rather invested in the trial. So the study didn't meet its primary endpoint, but what was interesting in this study is that the overall response rate in both the standard of care and the imlifidase group was much better than we would have anticipated based on the recruitment criteria of poor kidney prognosis. So around 60% of patients in both groups did not require dialysis at 6 months, and we were predicting that we would have 20% kidney survival in the control group. And I'd highlight that there was a very aggressive plasma exchange regimen in this study. So patients received daily plasma exchange until their antibodies became negative. If the antibodies come back, you reinstated daily plasma exchange. Our first patient in the study received a total of 42 plasma exchanges over a kind of 7-8 week admission to hospital. He was anuric and on dialysis at presentation, didn't receive imlifidase, but with very aggressive plasma exchange did recover kidney function after the first 3 months. So I think the trial still has some useful findings that with very aggressive treatment and really being very aggressive with plasma exchange to remove these circulating antibodies, perhaps patients do better than we expect. There may still be a role for imlifidase if it's as good as very aggressive plasma exchange. Certainly as a patient, if you offered me a 6-week admission to hospital having 42 plasma exchanges or a single dose of imlifidase, I know which I'd take. I suspect the hospital managers would probably rather give the imlifidase as well, because I suspect it would be cheaper than a very long admission having lots of plasma exchange. But we still await really further data from this trial because we've really had only the headline data, and I think the full results are expected at one of the nephrology meetings later in the year, either the ERA or the ASN. So then, time permitting, I've just got 2 more short cases. This is a young man who was 25, fit and well, no medical history, and a non-smoker, who presented to us in July 2020 during the COVID pandemic with a ruptured Achilles tendon whilst playing football. And he had that repaired under general anaesthetic by the orthopedic team. And 72 hours later, after this general anaesthetic, he presented with hemoptysis, dyspnea on minimal exertion. He was a little bit hypoxic with saturations of 94% and had a low-grade fever of 37.8. He had a 2.5 gram drop in hemoglobin and a modest CRP of 21, did have bilateral interstitial shadowing on his chest X-ray, but normal kidney function for his body habitus and negative urinalysis. Of course, this was July 2021, so we had about 4,000 COVID tests thinking this was pneumonitis, but it was not. This was his cross-sectional imaging showing typical features actually of alveolar hemorrhage. He had a very low titer anti-GBM antibody of 8.7. So this is an assay that runs to 650, but we did confirm the presence of circulating anti-GBM antibodies in a Western blot. It's not a very pretty blot, but you can see the band at 137 for anti-GBM antibodies. The rest of his serologies were negative. He had no viral infection. He had a diagnostic bronchoscopy that showed hemorrhagic fluid and about 30% hemosiderin-laden cells. So actually imaging and bronchoscopy findings that were very convincing for lung hemorrhage with very low titer anti-GBM antibodies. He was treated with rituximab and steroids and did very well and had resolution of his lung problems and has been very well during long-term follow-up. So an unusual or atypical case of anti-GBM disease, I would say. Then this final case of she's 51, again, no past medical history and non-smoker, who was referred to us with hematoproteinuria in February 2022, again, as it happens after a COVID infection. She had a creatinine of 125 and a urine PCR of 125 with dipstick hematuria. And her kidney biopsy contained 25 glomeruli, 8 of which were segmentally scarred, 3 with fibrocellular presence and fibrous presence, 4 with endocapillary proliferation, and 15% IFTA in the background. And the immuno on the kidney biopsy showed linear IgA 2+ without any light chain restriction and no deposits on electron microscopy. She had no circulating anti-GBM antibodies. She had no autoantibodies at all. We couldn't detect anything via Western blot in the research lab. She had no other reason to have false positive enhancement of her basement membrane. She was non-diabetic. She had no paraprotein or B-cell dyscrasia. She had negative virology. So perhaps fitting within the spectrum of what's become recognized as a typical anti-GBM disease. We treated her with MMF. And with that treatment, you can see during long-term follow-up, her kidney function has been stable and she's had persistent low-level proteinuria. I can't really attribute that to the treatment of MMF, but we don't know what would have happened hadn't we given her immunosuppression. But again, another unusual or atypical case of anti-GBM disease, but clearly very different from the preceding case of the young man who presented with isolated lung hemorrhage. The challenge is that in the literature, both these cases might be described as atypical, and the term atypical anti-GBM disease has been used to describe a lot of different things. So it's been used to describe uncommon clinical presentations in patients who've otherwise got typical immunology. It's been used to describe anti-GBM disease when it presents with dual glomerular pathology. It's been used to describe immunologic variants of what is otherwise very typical anti-GBM disease as some of the isotype and subclass variants. And it's been used to describe seronegative cases that have otherwise had entirely typical clinical features like rapidly progressive glomerulonephritis and diffuse alveolar hemorrhage. And I fear that atypical anti-GBM disease is the new FSGS, that we all mean something slightly different when we use the term atypical. So we think this is a new phenomenon, but actually I don't think it is. If you go back to some of those historic papers from the 1970s that I showed you at the beginning of the talk, this is a table 4 of the patients without lung hemorrhage in the original description of anti-GBM disease. And you can see in this table there were 3 patients who had tissue-bound anti-GBM antibodies on their kidney biopsy, but who had no circulating anti-GBM antibodies. They received only treatment with steroids or with steroids and azathioprine, 1 patient with steroids and cyclophosphamide, but without any plasma exchange. And with very minimal treatment, all of these patients were alive with normal kidney function after long-term follow-up. So clearly these patients were not the typical anti-GBM disease as we recognize it. And I think these atypical cases have been around for as long as we've had the disease itself. I don't like the term atypical. I think the descriptor glomerular disease with idiopathic linear IgG deposition may be more useful until we have better classification for this disease. This was a terminology that we put together actually with the French Nephropathology Society. I'm not a French nephropathologist, but my colleague Candice Ruffos contributed to this study and we provided some of the clinical data. So these are cases with no identifiable circulating anti-GBM antibody, but with linear IgG along the GBM in the absence of any other known cause. They typically present with progressive proteinuric CKD, but without rapidly progressive glomerulonephritis and without lung hemorrhage. On the kidney biopsy, they tend to have mesangial or endocapillary proliferative GN alongside secondary FSGS, but they do not have the typical diffuse crescentic nephritis that we see in anti-GBM disease. Importantly, around half of these patients show light chain restriction on the kidney biopsy, though none have an identified dysproteinemia or B-cell dyscrasia. They have a chronic relapsing course, unlike anti-GBM disease. And recently, there have been case reports of recurrence after kidney transplantation, particularly in the monotypic forms, suggesting that some of these cases may be caused by a circulating monoclonal protein. The immunopathogenesis, the classification, and the optimum treatment of these patients really isn't clearly defined, and clearly we need to try and understand the spectrum of this disease a lot better going forward. So I'll just wrap up by saying we recently published a treatment standard in NDT, which summarizes a lot of what I've talked about today. If you're interested, including this treatment algorithm, I'll not go through it in detail. But I'll conclude by saying that anti-GBM disease remains a medical emergency where rapid diagnosis and treatment are still the fundamental determinants of outcome. Starting treatment for patients on dialysis, really important. Risk stratification is important, but I think we should avoid therapeutic nihilism. Even in patients with those adverse prognostic factors, 15% with treatment might recover kidney function. Double positive disease deserves to be considered as a distinct clinical phenotype because of that relapse risk and the requirement for long-term immunosuppression. And emerging therapeutics such as IDES may reshape the management of severe disease, but we await further data from the phase 3 trial. And clearly the spectrum of disease is much more heterogeneous than was previously appreciated, and more precise classification systems are needed. So I'll conclude by thanking all of my colleagues in the vasculitis service at Imperial and very happy to take any questions.